Good afternoon to you, ladies and gentlemen. This is O.P. Yadav, CEO of National Heart Institute and Editor-in-Chief, Indian Journal of Thoracic and Cardiovascular Surgery. And we are here in Jaipur on the sidelines of the second annual meeting of the Society of Minimally Invasive Cardiovascular and Thoracic Surgeons of India. It's indeed our privilege to have Professor Prem Rabindranauth. Welcome, Prem.
Thank you.
Dr. Rabindranauth is the Chair of Cardiac Surgery at Gunnison Health System in Wisconsin, USA. What shall I say? Naturalized American now, but does have some roots with India, 6th generation backs. So I'm sure that must be giving you goosebumps to visit your land of the ancestors.
It absolutely does.
Well, Prem, how long you have been practicing minimally invasive cardiac surgery?
Well, I've been practicing cardiac surgery altogether for about 15 years, and soon after adopted off-pump, which in some ways could be considered less invasive. Yeah. And once we developed that program, we started doing minimally invasive mitral valve surgery through right mini thoracotomy. So I would say at least maybe 12 years for that. And minimal invasive bypass surgery now, at least 7 to 8 years.
If I can, what was the need for you to change from sternotomy to minimally invasive? And I'll be more provocative. Was it really you were concerned for patient, or was it that the kick we, the cardiac surgeons, got from our cardiology colleagues when they came with percutaneous options and we were forced to develop a response? So was that reactive? Or was it something you are convinced is needed for cardiac surgery?
I think a combination of things, some of the factors you mentioned, but I think the one thing I would add as well, especially when we developed our minimal invasive coronary bypass program, patient demand. And I say that because, and the story I tell, when we got started, we had a 45-year-old lady that needed 3 bypasses. And, I went in the morning to meet her for surgery, and her husband said, by the way, hold on a second, I have a couple of questions. He had gone home the night before and looked up a bunch of things online, because we have these resources now, and said, well, what about a hybrid approach? This was at least 8 years ago. What about doing one bypass through a little cut? And what about putting a stent in another one? And what about treating the other one medically? It really got my attention, because I didn't expect a layperson to know all these things. And I said, well, sir, we practice evidence-based medicine here. We don't do all these things. They're fairly new and experimental, and it's not proven. And the patient subsequently went elsewhere for exactly what they described. 2 weeks later, I got the letter from a cardiologist saying she had a robotic CABG. That's what the cardiologist said to me. The letter said robotic assisted, as we know, CABG. Take down the mammary, do the one bypass, stented the right, and treated the circumflex medically. So that got our attention. And that cardiologist called a meeting with us and said, what are we doing here? We need to start looking at things and thinking outside the box a little bit, because these technologies are there, they're being done, patients are coming in asking for these things. We ought to be able to offer them as well. So that's what that is.
So do you think that people who are practicing maybe 50 years plus kind of an age group, sternotomy surgery should change to minimally invasive, or should we bring up a new generation of minimally invasive trained surgeons who should be doing these surgeries, and the 50 plus retain the sternotomy option? How difficult is it, in other words, to convert?
So I think the learning curve is steep. It is a little bit difficult. I think that's a very intriguing question. It's always hard to get the older surgeons to adopt new tricks, or to teach an old dog a new trick, as they say. And it's also difficult to say, let's take all the new graduates, train them how to do this, and get them out there to start doing minimal invasive surgery. Because I feel to be able to do it, you have to have some experience. You have to be able to be proficient at doing cardiac surgery the routine, old-fashioned sternotomy way first. Because you have to be able to know how to get out of trouble, for example. Minimal invasive is a little tougher. As I say to patients and even surgeons that come watch us, it's the same operation, it's a different approach. You're not used to doing it that way, you have to get used to it. So it's not that easy to say, well, it's the exact same operation. We're just going to stand on the other side of the table and do it through a small cut now. So I think the learning curve is steep, but if you have the right surgeon with the right mindset, with the right program, the right team, etc., and you pick the right patient, then it's not so bad. So I think it's not a yes or no answer, you know, can we have everyone doing this?
When you said in generic terms, the right mindset, the right surgeon, what can you be more specific? What are those qualities
Yeah.
which will qualify to be called the right doctor?
I would think you have to have the confidence, first of all, right? You have to have the ability. We're all different. We're not all equal. Everybody has different technical abilities and manual dexterity and all that. There's no real way to measure that. So I think coupled with your ability, you have to have some confidence. You have to know your limitations, in other words. You know, we can't all rush in there and say, let's do this because it's the new thing and patients want it. I might ask the question, can every surgeon that you know do a mitral repair or an ascending aortic circ arrest case? And the answer is probably no. We all have our niches, you know. So we have to be able to be confident and comfortable with our team and all the other characteristics it takes, I think, to be able to start a program and to do it successfully. And then certainly you have to have the volume. We can't be doing something new and only do a handful of it per year.
So if I were to borrow a euphemism that you yourself used, is this a niche specialty not meant for consumption in the real world by every cardiac surgeon? And would it hurt the ego of that cardiac surgeon and they would like to join the bandwagon? So how do we prevent that happening? And we say, okay, you are doing conventional surgery, take pride in what you are doing, stay put with it, rather than being made to look an inferior surgeon if you were not doing minimally invasive.
Very intriguing questions. Your questions are getting harder now. I think, again, going back to what I said, you have to have that mindset, that confidence level. You have to know if you're going to be able to do enough of these to become proficient. You can't, again, do a few here and there, you know. And I see nothing wrong with having your niche because there's a lot of different things now. As you know, with technology getting better, we're finding new ways to do the same operation, for example. And take, for example, the hybrid method. I think that could be the new wave. And I think if we're going to be looking at doing a Lima to the LAD through a right mini thoracotomy, all of a sudden we take minimal invasive coronary bypass surgery and to me made it a few notches easier. Because to do a Lima to LAD is quite a bit easier than to do multivessel revascularization through that small opening. And I think that might open things up to even more of these surgeons who, you know, may feel inferior per se.
Well, I don't know. I mean, the science has to answer the aspirations of the society and match those. And in a country like us, India, developing country, hordes of people who are impoverished, will hybrid technology be the way to go forwards? I really, I don't have the answer. But is non-inferiority that we have proven of most of these techniques, is that good enough to make that push, so-called push to the Kaizen? Is that enough, or should we really be demonstrating superiority and then we say with dogma that's the way to go forwards?
I absolutely agree with you. I think we have to be able to show that any new method, any new procedure we do is at least comparable to the old method, right? And we strive to show that maybe it's a little bit better. Unfortunately, it's hard to develop these big series, you know, randomized trials, and we have smaller series coming out of various places, the so-called experts, you know, and that's all we have to go on. And conferences like these that you have here today, it's very nice because you have guys who've been doing the same type of operations and are proficient in it to share their knowledge. I think that's very helpful as well.
Well, ladies and gentlemen, we've just had the views from Prem, very candid, honest views. Minimally invasive surgery has probably not reached that level to say that, look, it's available for public consumption in a generic fashion, if I can use, for a bourgeois class of surgeon. It's still a niche specialty, but it is evolving, technology is evolving, the individual techniques and skills are developing, and probably the new generation, which has been sort of in their childhood bred on techniques which develop hand-eye coordination, video games, and so on and so forth, probably they will certainly take this specialty forward, and times look promising in the future. Well, thanks, Prem, for being with us.
Thank you, sir.
Thank you.